Hello, and welcome to Visionary Medicine, the next era of retinal disease treatment and patient adherence. I'm your moderator, Rachel Deer with DKB Med. Thank you so much for joining us. And here are our esteemed faculty, Dr. Grayson Armstrong from Harvard Medical School and Dr. John Kitchens from Retina Associates of Kentucky Eye Care Partners. Dr. Armstrong and Dr. Kitchens, thank you both so much for being here.
Thanks, Rachel. Thanks for having us.
Yeah, thank you so much, Rachel. I'm excited for this.
And here are our faculty disclosures. This activity is supported by educational grants from Genentech and Regeneron Pharmaceuticals. All activity content and materials have been developed solely by the planning committee members and faculty presenters. This accredited activity is jointly provided by Partners for Advancing Clinical Education, or Partners, and DKB Med. Partners designates this enduring activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. In support of improving patient care, this activity has been planned and implemented by Partners for Advancing Clinical Education and DKB Med. Partners is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. And here are our learning objectives. Discuss effects of delayed and interrupted treatment for DME, and evaluate the benefits of newly available anti-VEGF treatment options for DR and DME that may improve visual outcomes. Let's move on to our pretest. Question 1. A 44-year-old man with DME missed a scheduled anti-VEGF injection early in the COVID-19 pandemic, delaying his care by about 5.5 weeks. According to a retrospective cohort study, what was the observed average effect on visual acuity associated with this delay? A. Gain of 1.5 letters. B. No change. C. Loss of 1.0 letter. D. Loss of 3.5 letters. Please select your answer. Question 2. In a real-world study of people with DME who delayed treatment for at least 24 weeks after clinical recommendation, which of the following was observed? A. Improvement in both visual acuity and in macular thickness. B. Improvement in visual acuity but no change in macular thickness. C. Worsening in visual acuity and no improvement in macular thickness. Or D. Worsening in visual acuity but improvement in macular thickness. Please select your answer. Question 3. Which of the following was observed at 96 weeks in the Photon trial, comparing aflibercept 8 milligrams at 2 different intervals to aflibercept 2 milligrams for DME? A. Mean improvements in central retinal thickness were inferior for aflibercept 8 milligrams at both intervals. B. Aflibercept 8 milligrams every 16 weeks was non-inferior to aflibercept 2 milligrams every 8 weeks for improving best-corrected visual acuity. C. About 50% of participants receiving aflibercept 8 milligrams maintained dosing intervals of every 12 weeks or longer. Or D. Aflibercept 8 milligrams was associated with higher rates of serious adverse events. Please select your answer. Thank you so much, everyone. We'll see those questions again at the end of the presentation. And now I'll turn things over to Dr. Kitchens.
Well, Grayson, I don't know about you, but this is really a unique way to talk about diabetes. We're going to talk about the burden of the disease. You're going to talk about treatment options, including our newest treatment options. But what's so unique is we're going to hear from patients, which I think is just awesome.
It's going to be really amazing to be able to bring in the patient perspective here. We often hear about the amazing technology and the advances in treatments here, but It's not every day that we get to hear from the patients themselves, and also tie in how the newer medications help the patients in their journey as they enter our offices. And so this comes front to mind. I had a patient recently who entered our office. Unfortunately, this patient had been admitted to the hospital for a few weeks due to heart failure. As this patient came back into the office, they had missed at least 2 or 3 injections, and their macular edema was much worse. They dropped a few lines in vision. The patient was frustrated because they admitted that they were losing vision, but of course they needed to have that life-saving therapy. And so they came back to me. We started the injections, and we're now trying to claw our way back to get that patient's vision back. Does that sound familiar to anything you've ever come across?
Yeah, Grayson, I'll tell you, we think about the burden of disease, and we're going to hear from some patients that have a tremendous burden of disease and are not uncommon for our patients. But I think we sometimes forget that these patients have a lot more going on. And just like your patient, they got admitted to the hospital. They didn't show up. You got behind the 8 ball with them. We forget that these patients have dialysis. They get infections. They end up hospitalized with DKA. And so that coming into the office every month, which is sometimes necessary, is just another thing to rack up. So yeah, not uncommon. And I hate it when I see that. And I almost can tell you to a patient, when I see a patient that's missed 5 or 6 months and they should have come in 3, 4 months sooner, and they're frankly a bit of an eye disaster. Um, I know something's happened because our patients want to be reliable, they want to see, they want to preserve their vision. So there's oftentimes a reason why they don't make it in.
And it might not even be things like dialysis, right? It might be that they want to go on vacation. They want to spend time at work. They need to support their family. They have elderly family members they're taking care of, or children, grandchildren. Life gets in the way. And so our visits are critical, and patients understand that. But we have to recognize that this is a big burden on patients in so many ways.
It absolutely is. I tell our patients there's never a day off from diabetes.
Yeah.
You can never take a break, and that's really, uh, I can't even imagine what it's like to have to live with this disease. Speaking of that burden of disease, I would love to roll in and hear from some actual patients. We have two really great patients, and we're going to hear from them in two parts. And we're going to hear about their experience in the clinic. We're going to hear from Ashley, and we're going to hear from Danielle. Let's go ahead and listen to some of their story about their experiences.
Once I started treatment with the injections, it was terrifying, absolutely terrifying. At one point, I was like, I'll just go blind. I do not want to have another injection. It caused me so much anxiety. Kind of really took a toll on my mental health in the beginning. It took a couple years for me to kind of get into the groove of them and kind of have some sense of normalcy with them, so to speak, as much as you can. But it was pretty terrifying in the beginning.
I initially started off on a generic brand of the eye injections. My provider told me he was noticing that it wasn't as effective, so we switched to another brand that I'm currently still on that's been working much better.
My treatment has evolved in the sense I used to get injections every 4 weeks and we'd alternate eyes. So the left eye 1 week, the right eye 1 week. And now that was pretty much with a generic drug. And over the years, it's been 10 years, I've tried probably about 4 different medications. And so it just, my treatment's progressed with the new drugs coming out. So as it is right now, I'm on the newest medication that's available right now. And I'm able to go 8 weeks between injections.
I have to leave early from work to make my doctor's appointments. And then after my injections, I come home and turn everything, all the lights off, and I take a nap afterwards for about 2 hours just because the irritation in my eye after getting the injection is pretty rough.
I've definitely had a huge burden on my life from the injections. It's affected every aspect of my life, especially in the beginning. I couldn't work because I would be kind of down for the count. In my bedroom in the dark, I would have severe pain, and sometimes complications that go along with that, with the injections. So I wouldn't be able to work. I wasn't driving after the appointments for years because I couldn't see properly. So that was very, very tough. And it takes a toll on everything in life, finances, marriage. I mean, everything. You have to cancel plans with friends.
I would say when I get injections, I feel more confident about getting them, but I'm definitely still anxious.
Wow, Grayson. So that really, I mean, I know we talk to our patients every day, and we hear variations of this from every day, but I don't know that we ever hear it as completely as what we hear from Ashley and Danielle. And when talking about burden of disease, I think what stands out to me is that Ashley had 10 years of therapy. She was getting each eye injected on separate days, and if she was getting monthly injections for the first half of that, or more than the first half of those 10 years, and then every other month after that, she's probably been in the retina office 150 to 225 days over 10 years of her life. That really is incredible to think about, that burden that she has to do, and credit to her for sticking with it, especially considering how anxious she is when she gets these injections.
A lot of the themes they brought up are also the same. The fear and the anxiety, even though they're years into their treatment and they understand the value here, they trust their doctors, they love the care they're getting, but they still don't like the injections. They don't like to be there as often as they sometimes need to be. And so that's why it's so amazing that they recognize, we recognize there are new therapies, there's new opportunities to hopefully keep them out of the office for longer, but keep them treated with just as much efficacy, if not better, in the future.
Yeah, and that's why I always love to talk about new therapies with patients, even therapies that might not be approved but on the horizon, and try to find ways to get these newer therapies once they are approved to our patients, because we kind of think, oh, one medicine might be 2, 3, 4 weeks better than another medicine, but for that patient, it's half the number of visits that she has to have. So now you're going from 24 visits a year down to 12 visits a year, which is still unbelievable to think about going to a doctor's office and having a full day consumed by that 12 times a year. But it's so meaningful.
Yeah. And so, these patients that we saw right there don't look super sick to me. If I saw them walking down the street, I wouldn't think twice that they might be somebody with DME or proliferative diabetic retinopathy. But these are the patients that are working age, it's affecting their vision. They're often having to miss work and have major barriers to seeing us. And so I'm really excited to hear you, John, talk about what those barriers are that have been studied, what we know that we can do to try to overcome some of those barriers, and what some of these medications are trying to address.
Well, thanks, Grayson. Let's jump right into it, and let's talk first about the global incidence of diabetes. And we can kind of see how diabetes and diabetic retinopathy relates to the most common condition I see, which is usually macular degeneration. Second most common is diabetes. And if we look right now, we have 415 million people worldwide that have diabetes, and that's going to increase significantly by 2040 as we have the aging of the population. And as a consequence, the number of patients with diabetic retinopathy is going to increase as well. And we have really great clinical studies that show that anti-VEGF therapy is the gold standard for treating diabetic macular edema. It also improves diabetic retinopathy, but mainly diabetic macular edema, which is the leading cause of vision loss in working age patients. The problem is when you look at the real world data, we don't measure up to what we see in clinical trials. And I think we have these great therapies, but we're really failing to execute on them as well as we should to see those same kind of outcomes. I mean, it's not uncommon in diabetic studies as early as RIDE and RISE, seeing patients that were treated with monthly ranibizumab having 2 lines of visual acuity improvement. And we're getting about half that actually in the real world. And that's disappointing. And I think there are several reasons why we're not seeing that. I think some of it is on us, that we are failing to appreciate the fact that we have to treat these patients aggressively. I know years ago there was a lot of talk about patients failing to get the number of injections they needed in studies for macular degeneration. Patients were getting 7, 8, or 9 injections, and in the real world, they were getting 4, and they just were failing to see the same outcomes because they were being undertreated. But there's also a patient barrier to care. We just heard from Ashley and Danielle about the psychological barriers. There's a financial burden that's really been emphasized lately with some of the patient assistance funds going away and patients having to cover more of their costs. There's the travel burden. Many of these diabetic patients can't bring themselves to the doctor's office because they're going to be dilated or they're going to have an eye injection. They have other appointments. They miss appointments because they're in the hospital, just like you alluded to with your patient. And so we can see that there's quite a few things that lead to that barrier of care on the patient's end too. Grayson, what do you think about that, and what can we do better to help overcome these barriers?
Well, how many of your patients have to not only come alone, but bring someone with them? And that takes two people out of the workforce and out of the care force for other people. It's kind of amazing what if you think about the numbers of hours and number of people that are having to kind of support this to keep people's vision. And so I see this almost on a daily basis. People constantly bring this up in the office. And of course, we have pretty quick visits in ophthalmology, but hearing those patient stories and hearing them explain it in their own words is really valuable because it brings this to life. These studies that have found these barriers to care, of course, it makes sense logically, but it's hard to put that in perspective. I mean, I'm lucky that I don't have to go in for every month injections in my eyes, but if I did, I can only imagine the barrier that would be for me. So yeah, it's very real. It's huge.
Yeah, and when I think about our macular degeneration patients, many times they're brought by a spouse and they're retired. But you're right, when you take two working aged adults out of the workforce, and sometimes they'll come in and they'll have their kids with them, and you think, man, like how hard is this? Because they can't get childcare, because they can't afford it and whatnot. I think identifying some of these barriers to care and actually trying to address them on an individual basis. But I think we need to do better as a profession addressing these on a global basis. There are certain risk factors that can lead to worsening retinopathy and barriers to care. Not having a primary care doctor, is a big one. Patients not being referred for eye screening examinations. I saw a few years ago that only about 50% of patients with vision-threatening retinopathy actually had routine screening eye examinations. And those two things go hand in hand. If you don't have a primary care provider, you're certainly not going to get reminded that you need to have your eyes examined. Patients who are uninsured, big barrier to care there. Underinsured patients, another barrier. And I think we fail to appreciate the fact that failing to be able to speak English in the United States is also in many places a barrier to care. And race can be a barrier to care as well as socioeconomic status. And I'll tell you, one of the big burdens to disease is when we see patients too late. And then they're going to require a lot of treatment, especially in that first year or two where we're trying to get proliferative disease under control and battle really bad macular edema. I think in many ways, if we can catch these patients earlier and treat them earlier, at least influence them earlier to get better control of their sugars, we're going to decrease that burden of care. There's a study that showed when you look at patients that have diabetic macular edema versus those that don't have diabetic macular edema, they spend about 12 days more in healthcare visit days than the patients that don't have any DME. So these patients already have a tremendous burden of care. The average patient with diabetes is going to spend about 17 days in the doctor's office. But if they've got DME, add another 12 days to that. That's 12 days. That patient's spending almost an entire month visiting doctors. And a third of that is actually going to be because of their eyes and their eye care needs. We also know that patient non-adherence is a big issue. And depending on how you define non-adherence, anywhere from 17% to 35% of patients are not adherent. And I think we have to do a better job of talking to our patients and educating our patients. I believe that a patient that understands how diabetes is affecting their eyes and really appreciates the fact that if we catch this right and we treat this aggressively, really nobody should go blind from diabetes. and that this is very preventable. I think about our diabetic patients and just how they're constantly given bad news. You're not doing enough, your kidneys are failing, you might lose a limb. We have a real positive role to play here in that we can tell most patients with diabetic macular edema or proliferative diabetic retinopathy, we can make you better. But we can't make you better if you're not coming back, and we can't make you better if we're not treating you. I think about the IRIS registry, which is just an absolutely fantastic registry set up, the American Academy of Ophthalmology. I think almost all ophthalmologists are involved in the IRIS registry. And when we look at the number of patients that receive anti-VEGF therapy, over 10% are lost to follow-up and don't have any follow-up over a year after their initial treatment or their treatment with anti-VEGF therapy. And that's something we have to do a better job of. And I think the real fundamental thing you have to do there is talk to your patients, show them the images, and then show them how they're getting better with their treatment and really engage the patients. Grayson, what do you do to help try and motivate your patients to come back and to be inspired about getting treatment rather than dread it?
Showing a patient their OCT is a little confusing the first visit, but if I can coach them through what they're looking at, that becomes the mainstay of the visit. I have my technician pull that image up, and they know before I do, and I walk in the room, whether they're better or worse, and they hang a lot of, their hopes and their fears on that image that day. And so I love to be able to show them, especially early on for patients with DME, that it's making a difference for their vision. It's making a difference in the anatomical structure. And even if their vision isn't getting better yet, if you show anatomic improvement, then you can say that, we're starting the path towards improvement. We're getting there now, but the vision may follow. You have to keep up with this. And you can show them if there are lapses that you say, okay, I understand. We had an event. We had something happen in the family. You had to go away. But now that we had some worsening here and the vision's a little worse, we can get back on track. And it is a way of motivating them and educating them and teaching them and keeping them a part of the care team. They're almost important in the decision-making process as you are. They understand what the injections are doing. And of course, keeping the family involved, right? So educating the family in the room too, whether it's their child, their spouse, their parents, even their friend that's bringing them from home. I think that they get as invested and involved in this as you do and as they do. And so the whole group together is really just hoping that there's improvement at this next visit. So that's what I do. What about you?
Nothing makes me feel better than when I walk in the room and it's just a visit for an injection, but we always get an OCT to see how they're doing. And the patient points at the screen and says, look at how good I'm doing. Because that tells me that the patient's educated, that they're engaged and they get it. And I just love it when I have those kind of interactions. And I feel bad when a patient says, now, what is that? And what are we doing these shots for? And you think to yourself, man, I failed this patient that they don't understand why they have to get a needle put in their eye. Maybe after the first injection, you kind of have to reinforce like this is what we're doing and this is what it looks like to get better. But if they're coming in for their sixth or seventh injection and they say, now, what are you treating me for? I think, oh, I've lost such an opportunity to educate this patient and engage this patient. And those are the patients that I stop and I sit down and I re-explain everything to them because I really feel like they need to know what's going on with their eyes and understand what improvement looks like.
There's some educational handouts that we'll talk about later that are really helpful in various languages that can get to the patients, at their reading level. The average reading level in the United States is somewhere from the 6th to 8th grade, and talk about the disease in terms that they understand. And they can keep these at home and really rely and look back on this if anything gets confusing in the future. One of the other interesting things I do is I always ask them while I'm preparing the injections, do you have any fun summer plans? Any fun plans to travel in the fall? Any winter plans to go up to the mountains? And that's my way of keeping them informed that I understand that they're human. They're not just here to see me constantly, and they have lives outside of that. But if they do have plans, I can at least help plan around that future travel, and we can work together to collaboratively find a way to make sure they're getting the treatment they need.
And I love talking to them about just how good the anti-VEGF therapies that we have are. And not just for diabetic macular edema, but diabetic retinopathy. We've been a part of the DRCR network of studies. I mean, Boston, you guys are the home of the Joslin Diabetes Center, and I know you see a ton of diabetic patients. But I love the diabetic DRCR network studies. They're such profound studies. They're really original. They do have some drug company sponsorship, but the drug companies are hands off on this. This is really run by clinicians, and it's a great thing. And one of the studies I really like is the Protocol S study. And what the Protocol S study did was it looked at patients with proliferative diabetic retinopathy and randomized them to anti-VEGF therapy or laser. And I feel like in that study that the anti-VEGF therapy had several advantages over laser. A, patients don't like laser. It hurts. If you ever do PRP laser on a patient and give them a shot, they'll say, man, I'll take that shot, over the laser any day of the week. And I'm not saying there's not a role for PRP. There definitely is. But when you look at the control rates with the Protocol S study, it's pretty equivalent between intravitreal ranibizumab injections and PRP laser treatment, and maybe a little bit of a less of a chance of progression of attractional detachment and whatnot with the anti-VEGF. But if you take that study and you look at it in the real world, and we look at patient loss to follow-up, in the real world, doctors who tried to apply the Protocol S criteria, we see almost half those patients that are lost to follow-up. And those are the patients that you're really wishing you did PRP on, because when they show back up, they can have raging proliferative disease. But when you look at how we adhere to that Protocol S criteria as far as giving the patient the number of injections that they need, but we don't do a good job either. We undertreat those patients. So we're about 90% non-compliant with doing the treatments the way they did in the Protocol S study. So it's a little bit of both. We don't do quite as good as we should probably with treating these patients, at least with anti-VEGF, and then patients, are lost to follow-up. And I think sometimes those things can actually go hand in hand, because if the patient's not seeing the kind of visual acuity outcomes that we have come to expect from these clinical trials, they're not going to be motivated to come back. They're going to feel like they're failing. And that's something I feel like we can all do a better job with as far as that goes. And we know that the patients who are non-compliant lose vision. They don't see the visual acuity gains that we can see. And we've seen that in simulated Protocol S studies in the real world. These patients also have higher rates of vitreous hemorrhage, retinal detachment, and needs for vitrectomy. So, those patients that we try to manage like Protocol S, unfortunately, we don't do a good enough job. And when it's not in a rigorous study where you've got a clinical investigator on the phone all the time, calling those patients and making sure that they're coming back for their study visits, we see a loss in both, visual acuity and some of those end-stage complications that can lead to need for surgery and permanent loss of visual acuity.
One of the interesting things you just presented, it was a little buried in there, I think, but the patients with DME are more likely to be adherent than those without DME, and that's probably because their central vision is affected. It's something they notice and they can really have a tangible effect on. And if they see an improvement, I think they're very motivated to maintain that or improve further. And so for patients with DME specifically, I think we have the advantage of being something that they are tangibly aware of. For DR, for PDR, if it's peripheral disease and it's causing peripheral detachments, they may not realize that they're losing vision and they're high risk. And so for those patients specifically, we have the goal of education front of mind. We need to make sure that they're as invested as we are in their care.
Yeah, and we can see it with diabetic macular edema. We can see patients who have even a missed injection with a lapse can have increasing thickness of their edema, decreasing visual acuity. Sometimes it wakes them up and they come in and say, hey, listen, I really know I need to have these injections. And other times it can lead to further, fail to follow up and whatnot. And I look back even as early as the RIDE and RISE studies. And these are such great studies, monthly ranibizumab for diabetic macular edema. And we can see outstanding visual acuity improvements over 2 lines of visual acuity. But what they did in these studies, it was so unique, is they had a control group. There was focal laser treatment, and those patients gained about 2 letters of visual acuity as opposed to 12 letters on average in the anti-VEGF treated patients. But those patients that were in the control group after 2 years were eligible to get anti-VEGF therapy. And they never gained close to the same amount of vision as the patients that were treated right away. And didn't have the same decreases in thickness in the retina either. And so we see that they gain less than a line of visual acuity. So delaying treatment absolutely costs patients vision, and we have to do a good job of treating them promptly.
Yeah. I mean, you heard about the fear and the anxiety these patients had that we heard from Danielle and Ashley. And that fear causes a lot of people to want to delay, push off their treatments until it's maybe too late. And you see here from the Rise and Ride study that even after what, many months, these patients didn't get back the same vision as the patients that started the injections and the treatments earlier on. And so that delay costs people vision, sometimes permanently.
And we've seen that as recently as a 2023 real world study, as a single center study looking at treatment naive center involved diabetic macular edema patients. And they looked at the patients that were treated right away versus the patients that had a delay. And this delay was only about 6 months that they were delayed in getting their treatment, just a little more than 6 months. And what we see is that those patients that were treated early had increases in visual acuity and decreases in their central foveal thickness versus those patients that were delayed didn't see the same visual acuity benefits. So with the Ride and Rise study we just talked about, that was 2 years of delay. And I don't think anybody would let someone sit around knowingly with diabetic macular edema for 2 years. But, 6 months can happen, and that can actually cost vision. So it's really important to think aggressively. And if you can, I try to treat my patients the same day as their visit. I know we're clogged down with a lot of prior authorizations and benefits investigations, but if I can at least start the patient on anti-VEGF injections that day, I think there's less of a chance of loss to follow up.
I just think that this has really set the stage to understand the patient's perspective in a novel way. These aren't always the studies that I think physicians go to. We want to understand how the medicine works and how well it does, but we need to learn more about the patient's experience. And this has showed us that it's not uncommon to delay initial treatments. It's not uncommon to miss treatments and to have gaps in your care.
Grayson, we can actually see some of the effects of delayed treatment and delayed care from COVID. I mean, we saw it really noticeably with retinal detachments, where patients couldn't get into the eye doctor, so they didn't get diagnosed with the retinal detachment. They came in once the kind of closure of clinics was lifted, and we saw so many people with macula off retinal detachments. But we actually even saw that affecting patients with diabetic macular edema. Patients who missed a visit because of COVID, and usually it was just about a little over a month that they lost as far as engaging in their care. Those patients lost an average of about a line of visual acuity, while the patients who were able to stay consistent with their visits and not miss any visits actually gained just a little under a line of visual acuity. So that net is about a line and a half, or just a little bit more than a line and a half from COVID itself. So it's interesting what we continue to learn when we see these absences and missed care.
Yeah, it's the real world study nobody asked for, the natural history study. And so when lockdown took place, I think we all saw that tangibly in our offices, and the data is there to prove it too.
So, Grayson, one of the exciting things is always new treatments. And uh, it feels like lately, with so many second generation things kind of coming about and second generation treatments, that the landscape's changing very quickly. But in hindsight, I mean, gosh, it's been 20 years now that we've had anti-VEGF therapies. Talk to us a little bit about some of the changing landscapes of anti-VEGF treatments.
Absolutely. I'm excited to talk about some of these new technologies and new treatments that we have for our patients. But first, let's hear from our patients and hear what their experience has been like as they've tackled this kind of landscape and experienced these treatments themselves.
I'm satisfied with my current treatment. My doctor is wonderful. I mean, in a perfect world, I wouldn't want to get shots.
I'm thankful to be able to be on the medication I'm on because it's given me the longest space between injections. Obviously, I would love to one day not have to need these injections.
I believe more weeks in between treatment would be great.
It's a very long appointment. It's many things that go into it, checking your eye, doing, checking the pressure, getting you numb. But sometimes it takes, 3 hours, sometimes 1 hour, but it's a very, very long day for us, and we're so stressed out already, even if we've been getting injections for years, that it would be nice to somehow find a way to make it a little quicker and maybe make the numbing after last a tiny bit longer, because it tends to last about 15 minutes, and it'd be nice if we could be numb a little bit longer if possible.
I think that at every doctor's visit, it would be nice for some reassurance. Obviously, every time it's not going to be perfect, but I think reassurance just because it is an issue that's constantly on your mind. I don't think there's a day that goes by that I don't think about my eyes or my eye conditions.
I hope there's drugs that just keep coming out that can make us go longer, you know, longer without having to go back so frequently. And I'm hoping for one day there's just a treatment that will take this away completely, because it really does take a toll. And we can get used to it. I'm used to them now, but they still affect our life greatly, and they're very painful.
Normally, patients don't want to be at the doctor's office, so just being as compassionate and I guess knowledgeable is great.
So I found a lot of community in on Facebook and type 1 groups, retinopathy groups, diabetic macular edema groups. Social media was actually very helpful for me, because there's not a ton of people, especially when I was diagnosed at around 30, that was suffering with this yet.
Okay, so right away, John, it's clear that these patients love their doctors, they love their care teams, and they understand the value of what they get. But it doesn't go without saying that they don't want to be in the office every day. They really want to find ways to solve this permanently and get really long extensions between those office visits and maintain their vision for that time in between. And so if you go back to the beginning, there's a few medications during the first generation of anti-VEGF that kind of set the stage and proved the worth of these treatments. The first is aflibercept, here ranibizumab, and then of course off-label, but bevacizumab. These medications are injected into the eye, they target the VEGF receptors, and they do an amazing job at preventing, worsening, and even improving DME and PDR. And so as we've moved past these first initial waves of treatments, we've gone to the second novel wave of therapies, some of which include 8 milligram aflibercept, which is 4 times stronger of a dose than its prior generative product. You can see the ranibizumab port delivery system, which is implanted surgically into the eye, and it provides constant elution of those medications into the eye for months at a time. And then you have faricimab, which is a dual-acting agent that's targeting not only the VEGF pathway, but also the Ang2 pathway. And in doing so, it targets both the endothelial layers, but also the same classical pathway that we've been accustomed to as physicians. I guess, John, we've come a long way as a society of ophthalmology. How are you implementing these in the office?
Well, Grayson, I am just amazed by the science behind this. I mean, the ability to concentrate what used to be a 2 milligram product into 4 times the dose, and not have it be so viscous we can't inject it or have it precipitate out. The port delivery system is amazing. I'm a big fan of the port delivery system. To think that we have a 6-month treatment option for our patients with diabetic macular edema is really amazing. And the fact that we have an antibody that can actually bind 2 things is just so monumental, these discoveries. So I will tell you, I have completely embraced these treatments for our patients. And I think we heard it from Ashley and Danielle in that they started out getting monthly injections. And I'll bet you the reason that they're not getting monthly injections now is because some of these new therapies were utilized for these patients. So we all have our frequent flyers. We know these patients because we see them so often. And those are the ones that I really want to try to get these newer treatments for early, because I just want to give them a break.
Yeah. I mean, Ashley did say that she went from 4 weeks to 8 weeks now, and she's maintained there. But, in the future, who knows? Maybe she'll get out to 12, 24 weeks. It's really incredible what can be done nowadays. And the future is bright in this space too. And so, speaking of the science, let's dig in a little bit and talk about what the studies showed. And I think that the science really does speak for itself. In the Yosemite and the Rhine studies of faricimab, the dual agent, the dual target agent, we had three different arms. We had the Q8-week faricimab arm, which was compared to the 2 milligram of aflibercept every 8 weeks. But then there was a third arm, and this allowed for a planned regimen of treat and extend. And this was trying to see how far can patients get out with this therapy and still maintain their vision, still maintain their retinal health. And if you think about this, this is similar to what we do in our offices nowadays often. We don't want to keep patients at Q4 weeks forever. We try to find ways to extend. And this study tried to scientifically match what we were doing in our offices in a clinical trial. I think that was really innovative.
Yeah, I
So,
think that's absolutely the best treat and extend study I've seen. I mean, we don't have any treat and extend study as robust with the data and as many patients, and it's really an excellent study. I love that PTI arm.
yeah, the PTI arm was good at showing us that, as you can see here, you had incredible improvements in best corrected visual acuity in both of these studies, both Yosemite and Rhine, past 96 weeks. And then you can also see here that in both studies, you had incredible anatomic improvement in the retina. Now, of course, you have the seesaw effect of the Q8 weeks in those arms. And then with the PTI arm, because it was variable how often they were getting it, it kind of averaged out to be a flatter line. But in all three arms, they had incredible visual acuity outcomes and retinal anatomic outcomes. And in the end, it was non-inferior, the faricimab to the 2 milligram of aflibercept every 8 weeks. If you think about this, the PTI was really trying to see how far can patients extend safely and still maintain their vision. And according to the study, it shows that about 78% of patients can get to Q12 weeks or more in this study using faricimab. And that is far beyond the prior legacy of every 4 weeks, bringing patients into the office for their 12 visits a year. A Q16-week interval is what, 4 or 5 visits a year? That's giving them their life back. That's overcoming the barriers we talked about. This is the real way to tangibly impact and treat those barriers systemically and medically, is to keep them out of the office and not make them pay the financial, footprint of getting into the office, to bring their partner or their friend or their loved one into the office with them, to make sure that they don't have to rely again on the interpreter service to try to get through and communicate their fears and their anxieties here. And so this was an incredible study, and it gives us hope that the faricimab, it does an incredible job at extending for some of our patients.
Yeah, Grayson, this is what it's really all about, is that decreasing treatment burden. That's going to help our patients. It's going to help our clinic volumes. It's going to improve compliance. And it's amazing to think that we have 80% of patients in the Yosemite and Rhine study that are out to 3 months or longer injection intervals after an appropriate loading dose. But it's all for naught if it's not safe. What do we know about the safety of this product?
So the safety is incredible too. And so it was non-inferior safety events in these trials compared to the aflibercept arm. And so it's as safe as it is effective. So using these with confidence in your office, you shouldn't be nervous that you're going to have any more increased adverse events. Here we have the Photon study that compared the 8 milligram aflibercept to the 2 milligram aflibercept. And it took the 8 milligram dose and it did it both Q12 and Q16 weeks. And then in this graph here, in this table, you can see that it subdivided the participants based on their macular thicknesses and, in essence, their visual acuity starting out. And so they had four major quartiles, from very little macular edema all the way to pretty severe macular edema. In all of these groups, you had incredible visual acuity outcomes, and in the end, it was non-inferior to the 2 milligram of aflibercept that we are used to and accustomed to for so many years. If you look at the data here, it also helps with the anatomic improvements in the retina, and the safety events, again, non-inferior in terms of their safety profile. The one thing that I think people think about, John, is that it is a higher volume of medication. And so you have to inject 0.7 instead of 0.5 milliliters of of volume. So John, one of the things that people think about when they compare these two medications is the fact that one of them is, the newer medication is 70 microliters of drug, whereas the old one was 50 microliters of medication. And so you get, for just 20 microliters more, you get 4 times the pack of punch. So if you see here, there aren't that many patients that had hypertensive issues in the office in terms of their ocular hypertension. And of course, with patients with glaucoma, with tubes, with trabs, something to think about when you're using this medication. But I think that this study shows that there isn't a major concern in that realm.
And Grayson, I'll have to say that I've been using the aflibercept 8 milligrams since it launched a couple of years ago, and I've not had to do a single tap of the AC. Yeah, I do warn patients in advance, though, hey, listen, this is a little bit higher volume medicine, and so you might notice your vision dimming out. And most patients have actually had that happen at some point in the past, so they're a little bit familiar with it, but it can still be disconcerting for them. So I think just giving them a heads up of, hey, you might notice your vision going dim a little bit, it puts them at ease when it happens.
I agree. That's something that doesn't have to happen with this 8 milligram dose. It can happen with any of these injections. And so anyone with any sort of vascular compromise of any kind, they might get a little bit of dimming when the pressure goes up just transiently. But it is something that my patients have experienced too. I warn them about as well. If it does happen, I just have them sit there. We massage the eye for a few seconds while we kind of make a couple jokes. And by the time they open their eye again, it's usually gone and they walk out of the office just like they came in.
Now,
So
Grayson, what about durability of the 8 milligrams? How does it compare? We talked about increasing or decreasing the frequency of injections, increasing the durability. Do we see the same thing that we saw with faricimab?
yeah, we do. So if you look at the bottom right corner of this graph here, what you're going to find is that over 80, almost 90% of people were able to maintain a Q12 week injection cycle with the 8 milligram aflibercept. Or, that's incredible. Almost 90% of people can spend 3 months or more out of the office at a time and maintain their visual acuity and their retinal outcomes. And it gets better than that. If you look at the subdivision of this, you're going to find that there are patients that got all the way out to Q20 weeks or more. Some of them got out to Q24 weeks. That's like 2 visits a year to the office. These patients are coming in every 6 months or so. They're seeing you for their visit, they're getting their injection, and they get to spend all summer and all fall with their family at work. They're able to be productive members of society without fearing visual complications, and then they can come back and see you. And so it's made a huge difference for some of the patients that I've treated. We just heard from the fact that Ashley and Danielle have tangibly, felt this in their lives. And the fact that we have these in our armamentarium now is a game changer.
You know what I love is the fact that this is the same molecule as the 2 milligrams of aflibercept. So when we're talking to patients and saying, hey, I want to switch you to a different medicine, the conversation when you're switching someone from 2 milligrams to 8 milligrams of the same drug is so easy because you say there's nothing different about this drug. It's just a higher concentration. And then it allows me at least to go out longer almost immediately if that patient's already stable on 2 milligrams.
Yeah, it's true. It's something they're used to. It's something they've heard about before. It's something they've learned to trust. A lot of patients will ask me what the names are of these medications. They look them up at home. And so they're invested in understanding what it is that we're using in the office to help them. And this gives them the comfort that a new medication might not give them right in the office if you're trying to change them. So speaking of advances, there's another major advance that I know that you've had a large part in playing it scientifically, John, the Pagoda study with ranibizumab, the port delivery system where you surgically implant this device in the patient's eye. It provides a constant elution of drug into the eye. And then every 6 months or so, you can replace that medication for the patient. And it continuously gives them constant infusions. And so you can see here that there is ranibizumab is 100 milligrams per milliliter. You refill this every 24 weeks. The study was measured out to 48 weeks, and then the end of the study was 64. The study is interesting, but the way that I think about this is that this is comparing it against what isn't even necessarily the gold standard it's like even better than the gold standard, right? So you're giving people Q4 weeks ranibizumab 0.5 milligram injections, which is not necessarily even the one that we're using for these patients in the first place, right? We usually use 0.3. And so you're using this 0.5 milligrams, which is a higher dose at baseline. And it's really setting up like, if this is non-inferior, then it's a pretty good outcome. And so if you look at the best corrected visual acuity, it makes sense that right after surgery, the best corrected visual acuity drops just a little bit. But by the end of the study, there are certainly non-inferior outcomes for this compared to the Q4-week injections of the ranibizumab. And then in terms of central retinal thickness, again, non-inferior outcomes, amazing. It's really just incredible what this technology can do. I mean, who would have thought that you had a durable implantable device when we started out 20 years ago?
It's really amazing. I think 20 years ago, we would have killed for a surgical cure for diabetic macular edema or wet macular degeneration. And I'll tell you, I really love this device for our frequent flyers. You know, I was a little bit worried at first, like, gosh, if you're a frequent flyer, are you going to be somebody that it's going to make it 6 months? But actually, it works really well for those patients. And so this can be a real solution for our toughest to treat patients. But there's a couple of caveats with risks around the port delivery system. What can you tell us about that, Grayson?
Well, I know you've lived it, so I want to hear about your experience too. But if you look at the research and the study, it does show us that these patients do have a risk of cataract development. They have a risk of subconjunctival bleb leak or filtering bleb. And that makes sense if you're making an incisional surgery in the eye as compared to a small 30 or 32 gauge entry wound. They have a little bit of a risk of conjunctival erosion over that plate. They have some risk of hyphema, which makes sense. Again, it's a surgical intervention. They can have a little bit of bleeding, a little bit of vitreous hemorrhage, but interestingly, not an increased risk of endophthalmitis or retinal detachment in these patients. And so overall, some of these are things you can expect. And I think that given the fact that you can get persistent long-term treatments for these Q6-month intervals, some would say that the bleeding is almost going to happen no matter how you try to approach it. Some of these are almost expected outcomes. I don't know. What is your experience with this?
Well, I'll tell you, Grayson, what's really amazing, and you alluded to this in the study summary here of complications, is endophthalmitis. And when this first launched for wet macular degeneration, based off the Archway study, there was a higher rate of endophthalmitis, and that came from implant exposure and conjunctival retraction and erosion. And that got a label warning on the device itself. After that, we continued to modify how we did the surgery, how we monitored the patients, and frankly, we got better with how we did this procedure, particularly with conjunctival handling and conjunctival closure. And as you can see in the Pagoda study, those rates went down substantially. And so now you've got under a 1% chance of infection out actually in the longer term study out into 2 years. And so that's really comparable with getting injections every 6 or 8 weeks for about 2.5 to 3 years. So that's kind of your break even point if you get a lot of injections for risk of endophthalmitis being equivalent. But this really shows what a great study can do as you modify the surgical approach and decreasing that risk of endophthalmitis. And as a real tribute to the company that developed the port delivery system, that they worked so hard to reduce this complication.
Yeah. And I think that this is kind of answering a lot of the concerns that people have in the back of their minds when they're approaching something that they've treated with injections for so many years in a new, novel way. And so anytime you take a scalpel to the eye, it's a different set of risk profile that you're talking to the patient about. The patient's going to have to go into the operating room. It's a procedure as opposed to a very quick injection. And so I guess I'd love to learn from your experience how that surgery goes and what it's been like in your hands.
Yeah, so we've done over 20 of these procedures, both in the studies and now that it's been launched. And it's about a 30-minute surgery. You can do it with the patient awake and sedated. A block is necessary for the surgery. It's you have to think a little bit more like a glaucoma surgeon because you really have to be careful with conjunctiva and tenons. It's not what we're used to. There's not going to be really any surgery, any part of it that you're inside the eye doing a vitrectomy or anything such as that. But it's a very straightforward procedure when you understand the steps. But really, the happiest patients are the patients that have had this done because they're patients just like Ashley and Danielle that have had to come in every month or every month and a half for years and years. And finally, you can say, I've got something that I can put in your eye with a surgery, and then you come in every 6 months and get a refill. And by the way, because you're refilling into the device, the patient really doesn't feel it. So it's a painless refill procedure. It's got a little bit of a learning curve, but once you get it down, it's kind of neat and kind of fun to do. And very rewarding to know that you've just given that patient 6 months worth of treatment with one injection.
It's just wild how far we've come in such a short amount of time. And knowing that these things have just recently hit the market in the last few years and are available, a lot of physicians are thinking about this. And I'm just glad that we have the opportunity to talk about it today, both with our own experience and also with the research to back it up. So when we were listening to Danielle and Ashley just a little bit ago, they were talking about how they used social media to find like-minded individuals and to find resources to help them cope and understand what they were going through. And I think as physicians, it's actually imperative that we provide similar things to our patients to give them the resources that they would otherwise have to hunt and find on their own. Let's not allow them to feel alone in that journey. And so here are some of the resources that we've collated that we think might be helpful for patients. Number one, if you have automated text message reminders for your appointments in your office, and maybe even tasking a front desk staff, and in the future, maybe an AI bot can call this patient for you. These are things that can make sure the adherence is there, the patient is given reminders, and it's not up to them to keep it on their calendar. Let's help support them in that journey. Number two, we already talked about education. But I think education is probably the most important thing on this list. We need to make sure that they understand what the disease is, the risk of non-adherence, and the risk of delayed initiation of treatment. We know that there's data behind this. We can speak to them honestly and openly about the importance of making sure that they come in when they can. And if they can't, they need to communicate with us right away so that we can make sure we can plug them in. There's an ASRS fact sheet in various languages, in the language that patients can understand, that can be printed off for patients in the office. This is free for patients and for offices to use. You could print a couple ahead of time and just have them ready for your new patients that are coming in. And again, AAO, an amazing organization that's created handouts that can be given to patients on various topics, including diabetic macular edema. It helps educate them on the disease, the treatments, and what to expect. And so, John, let's go through the takeaways and see where we are.
Absolutely. So Grayson, I'll tell you, when we look at our key takeaways, patients with diabetic retinopathy, diabetic macular edema, really face a lot of barriers to their retention in care. Even brief lapses in care can result in worse visual acuity outcomes. We saw or talked about the COVID study that showed that patients who had a lapse in care of just 5 weeks lost 3.5 letters, while their counterparts that were able to make their appointments actually gained 2.5 letters of visual acuity. That when we delay the initiation of treatment in diabetic macular edema, like we saw in the RIDE and RISE studies in the control group that were delayed by 2 years, but even in the real world studies where patients just had a little more than a 6-month delay, we lost visual acuity and didn't see the gains that we came to expect from our treatments. These newer anti-VEGF options that you talked about, including 8 milligrams of aflibercept, faricimab, and the port delivery system with ranibizumab, are really great options for our patients to decrease that treatment burden. We saw you talk about the 8 milligrams in the Photon study achieving Q12 to 16-week dosing upwards of 90% of the time in the first year. When we look at the 6 milligram of faricimab treatments, we saw that they had that PTI treatment interval where it was really kind of a real world treat and extend, or as close to real world as you can with the treat and extend, with 80% of patients extending to Q12 to 16 weeks. And then the port delivery system where we had Q6-month dosing with equivalent outcomes visual acuity wise and OCT wise to monthly ranibizumab 0.5 milligrams.
We heard from Ashley and Danielle that these medications have made a tangible impact in their lives and have allowed them to be more visit-free and has extended the time between treatments for them, which is increasing their satisfaction but giving them just as great visual acuity outcomes. But John, do you have any cases that you want to talk about for similar outcomes?
Yeah, Grayson, I've got one of my favorite patients of all times, a 41-year-old female, Vicky, is her name. And unfortunately now she's passed away. I saw her more than a decade ago. And she, at the time that she came in to see me, she had a 15-year history of diabetes. Her A1C was 14 when she came to see me. And she came in because she had lost vision in her better seeing eye. And this loss of vision actually was due to a pre-retinal hemorrhage over the macula. And what she didn't realize is that her fellow eye had 2200 vision from diffuse macular edema. She just, as many patients, she thought it was a need for new glasses, cataract and whatnot. But when she had this sudden and significant loss of vision in her good seeing eye, she panicked and went to see the eye doctor. And he said, "Hey, you're going blind from diabetes." And so she came to see me. We got an angiogram, which showed extensive non-perfusion in both eyes, broad areas of neovascularization in her left eye and this premacular hemorrhage. So, in the past, a patient with a hemorrhage like this would have ended up in the operating room, but the power of anti-VEGF therapy was really amazing. So first and foremost, for her now better seeing right eye, which was 2200 in the diffuse diabetic macular edema, we instituted anti-VEGF therapy right away, and then later PRP laser treatment. And we can see with anti-VEGF therapy, her acuity went from 2200 to 2050, and she actually ended up 2025 in that eye. For her worst seeing eye, we started anti-VEGF therapy and prompt PRP laser treatment. And without surgery and with that very rapid anti-VEGF therapy, the hemorrhage cleared. And eventually, then we were only having to manage her diabetic macular edema. And with proper care, we got her vision down to 2100, and then we improved it further to 2050, switching through a variety of different agents. And what really makes me the most proud is this last image of her eye, her left eye, which was the eye that bled, when she came in with this massive hemorrhage over her macula. And without surgery and with extensive laser and injections, we were able to get her back to 2050. It changed her life, actually. She went from someone who had an A1C of 14 down to an A1C of 7. She stopped smoking. And she started to educate all of her friends and neighbors and people at her church about the risks of diabetic eye disease. And I would see patients come in and I would say, "So who referred you?" And they would say, "Vicky referred me." And I knew immediately who it was because she was telling everybody, if you have diabetes, you need to go see this person. Now, I don't need to see every diabetic patient. I think there's a role for primary eye care providers to screen patients and whatnot. But it's amazing how she became an advocate, not only for herself, but for other patients, and really turned her life around.
Congrats on a great outcome.
Legally blind to legal to drive. And
Yeah.
and she never forgot it, and was a character until the very end.
Well, thank you for sharing that, John. And so I guess now we can get to the questions and make sure that we had all of our CME credits. But John, thank you so much for joining us today. And thank you for joining me. Thank you for talking about your patients.
Thanks, Grayson.
I want to thank DKB Med for putting on this incredible CME. I want to thank the patients, Danielle and Ashley, and the other patients that we talked about today who shared their story and really gives us perspective on how these new treatments can make a tangible impact in their lives and overcome the barriers that otherwise keep people out of care. John, thank you for being here today too.
Thanks, Grayson.
Thank you so much to Dr. Kitchens and Dr. Armstrong. Now let's go back to our post-test. Question 1. A 44-year-old man with DME missed a scheduled anti-VEGF injection early in the COVID-19 pandemic, delaying his care by about 5.5 weeks. According to a retrospective cohort study, what was the observed average effect on visual acuity associated with this delay? A. Gain of 1.5 letters. B. No change. C. Loss of 1.0 letter. D. Loss of 3.5 letters. Please select your answer. Dr. Armstrong, please explain the correct answer.
The correct answer is D. Unfortunately, in this unforced natural history study during the COVID pandemic, patients who missed an average about 5.5 weeks of visits ended up with 3.5 letters of vision loss. This is opposed to patients who kept their appointments and gained about 2.5 letters.
Okay, question 2. In a real-world study of people with DME who delayed treatment for at least 24 weeks after clinical recommendation, which of the following was observed? A, improvement in both visual acuity and in macular thickness. B, improvement in visual acuity but no change in macular thickness. C, worsening in visual acuity and no improvement in macular thickness. Or D, worsening in visual acuity but improvement in macular thickness. Please select your answer. Dr. Armstrong, what's the correct answer here and why?
The correct answer here is C, where the patients had a worsened visual acuity and it did not improve their macular thickness. Unfortunately, this delay led to poor outcomes down the road.
And question 3. Which of the following was observed at 96 weeks in the Photon trial, comparing aflibercept 8 milligrams at 2 different intervals to aflibercept 2 milligrams for DME? A, mean improvements in central retinal thickness were inferior for aflibercept 8 milligrams at both intervals. B, aflibercept 8 milligrams every 16 weeks was not inferior to aflibercept 2 milligrams every 8 weeks for improving best corrected visual acuity. C, about 50% of participants receiving aflibercept 8 milligrams maintained dosing intervals every 12 weeks or longer. Or D, aflibercept 8 milligrams was associated with higher rates of serious adverse events. Please select your answer. Dr. Armstrong, what is the correct answer here?
The correct answer here is B, where the aflibercept 8 milligram given every 16 weeks was not inferior to the 2 milligram dose of the same medication given every 8 weeks.
Dr. Kitchens and Dr. Armstrong, thank you again for a wonderful presentation.
Thank you, Rachel.
Thank you for having us.
And thank all of you for watching. Please claim your credit by clicking on the Claim Credit button on your console, and please be on the lookout for a 30-day survey. Also, we have another webinar coming up very soon on AMD, and then our third and final webinar will be on RVO, so please check those out as well. Thank you again for watching, and see you next time.